Thank you very much for inviting me to speak at this prestigious event. It's really amazing to see so many diverse and informative people coming together to discuss the problems of drug use, which are so clearly exacerbated by bad policy. My background is that I was one of the early HIV harm reduction workers in the UK, and I went on to be a health service manager and was trained as a health service manager. I was particularly listening to the doctor from Uruguay speaking, and really some of your discussion around the nature of health as a policing intervention was when Tony Blair came into power and then changed our drug policy away from the famed British model that had been so successful in overcoming HIV, and then decided because we didn't have the imperative of HIV to keep a public policy attention on drugs, we should now focus on treating drug users as criminals and focusing on our impact on crime. Now, at that point, I could no longer be a drug service manager. I'd been a drug user throughout the time I was a health service manager. I was one of the early adopters of the acid house generation and had a reasonably prolific drug using career while still being a health service manager. Now, for me, there didn't seem to be a contradiction because half my management team were drug users, a quarter of my staff were drug users. We used community mobilisation very actively. However, at a particular point, I got to the point of feeling that I couldn't collude with a system where my community was suddenly being treated as criminals overtly, rather than when we had been so instrumental in overcoming HIV in our country. And I thought there was an incredible disloyalty from government when my community had stepped up and really been instrumental in changing the HIV epidemic in the UK, to then reframe us, and the only way we could access services by reframing us as criminals, for me was a terrible insult. And it led me to stand up publicly and walk away from my NHS career and come out publicly as a drug user. So in these slides, you can see right at the top you can see me without a beard in the old days, was a meeting back in the early 1990s where we met as drug users alongside the Paris International Harm Reduction Conference. At that point, we were meeting outside the conference. We had to hold a demonstration in the streets. We had no formal place in the actual harm reduction conference itself. And then the picture at the bottom is, I think, maybe 20 years later, and you'll recognise some of the other people in that picture as the more new leaders of the drug user movement. That's the drug users having just come out of a capacity building event in the UNODC building, facilitated by UNODC, working in partnership, learning how to be high-level advocates to engage in the Commission on Narcotic Drugs. So it really shows in 20 years, drug users have moved from being absolutely on the margins to being central to policy. And I just want to talk about this process from how this is going to work. Can we make it jump on? Or not? Oh, no, there we go. It's gone. Yep. Okay, so just to give you, I've given you some background about myself. So my local drug user group is called Respect. We are a grassroots drug user group. We basically predominantly work through street networks, through our drug dealing and drug supply networks. In fact, at this point in the UK, we have no engagement with the policy system because the new government recovery model we feel is a complete farce, and we're not going to waste our time sitting in meetings discussing unscientifically founded drug policy. We'd much prefer to spend our time educating our peers, and we now take a guerrilla approach with policy where we only engage when they threaten our services. Otherwise, I'm involved in COACT, which is a technical support agency. Now, technical support is a function within the UN, and we are a team of about 10 or 12 drug user activists and drug users from around the world who have dual professional backgrounds. So we play this role called bridge building, where we very actively try to create a dialogue between the professional and the peer worlds, because we stand in both. We try to speak the languages of both and try to help create connection, because my experience as a drug using health service manager was that there was something that happened when the drug users and the professionals came together, that we could create something that was incredibly special in the response that neither group could have provided on their own. And for me, Actually, many of my colleagues see me as having gone native. I'm seen as a sort of poacher turned, or gamekeeper turned poacher, that I've sold out and become. No, I so identified with with the drug users I worked with that I became one of them, was how it was once framed to me. But for me, I don't see drug users as other. I see drug users as my friends, as my peers, just as I see drug workers as my peers and my colleagues. So for me to step from specialising in being a drug treatment worker to specialise in being a community activist among drug users, for me wasn't a lesser step. It wasn't a degrading in my career. It may have affected my salary, but it didn't affect my belief or in the value of that work. And I'm very happy to have made that choice in my life. So I just want to look back at the history of drug user organising, and I'm particularly talking about drug users, what we might lazily call hard drugs, so like injecting the big stimulants, methadone and OST. So drug user organising has its original roots back in the 1970s. There's a longer history among psychedelic and cannabis drug users, but this is focusing at a different end. So in the 1970s in Rotterdam, a drug user group called the Junkiesbund came together, led by a very famous activist who's now unfortunately dead from HIV called Nico Adrian. And Nico set up a group he was an anarchist by background, and he used his street anarchist sort of activism strategies to bring his peers together and to respond to the problems that drug users were facing. And they did things like they ran a radio station, and in fact they ran the world's first needle exchange in 1982, not as a response to HIV, but as a response to hepatitis B. So far preceding the response to HIV. And when people tell you that drug users can't respond and can't be part of the epidemic, let me give you a list of everything that we innovated that you now do as part of your core response. But we innovated it because we are the ones on the front line, so we know what the consequences of not having needles and syringes are, because we're the ones sitting there in groups of 30 people injecting together with one syringe. We're the people sitting there watching people sharpening needles and syringes on matchboxes as they try to inject them again. So of course we are then at the centre of pushing for needle exchange to come in, because we understand the consequences better than anybody else. So the Junkiesbund started off in this street anarchist model. I think at some levels there was a mistake of letting go needle exchange, and we've seen the same in the UK, where needle exchange became very much a sort of statutory, almost like bank managing. It was like a bank rather than like a community activism, whereas we see in the US, for example, where needle exchange has remained much more of a community activity. It has a much more community development feel to it, and I would ask you to think about that lesson as you roll out harm reduction. Now, sometimes if you institutionalise things too much, the community lets go and steps back, and then you face what happened in the UK, which is the government changes policy, and then the community is left scrabbling to catch back up again. We should never have let go of those services in the first place. So the second type of drug user group, also formed in the middle of the 1980s, in 1970 and into the 80s, was a group initially called it's called a group called NAMA. They had an earlier name, but the National Association of Methadone Advocates. And this was a US group of methadone users coming together, and they're essentially a consumer group. They're consumers of methadone coming together to, one, advocate for methadone within the general environment and to fight for access to methadone, but also to fight for quality of methadone and a humane treatment system. Because I've seen disgusting human rights abuses treated. I managed a service where the doctor who I managed and had huge problems managing, if people turned up late for their prescription, would stand through a glass door and tear up their 2 weeks prescription in front of them, and you would see 30, 40-year-old blokes crying on the steps outside, trying to explain why the bus was late. And for me, that's one of the reasons I moved to being more politically involved, because for me, that wasn't healthcare. That was sadism dressed up as healthcare. So then we start to see a new form which comes in the 1980s and 90s, particularly typified by the Australian IV League, it's in what's now called the Australian Injecting and Illicit Drug Users League. And this is where drug users got involved in the harm reduction response. And for many of us in those, and this is the period I got involved in, for many of us there was a struggle to save our friends. I was involved in the days before ART, when we were delivering needle exchange, we were losing a lot of our friends, and it really felt like we were not sure that our community was going to be at least decimated, if not more than that. And there was a sense that harm reduction worked, but we didn't know it worked. It just seemed intuitively right to help people in this way. Now, the evidence now backs that up massively, but in those early days, we were really struggling because it was a real fight for the lives of our peers. Now, as that HIV epidemic came to an end, and I'm very conscious of that being a very UK dialogue, but as the epidemic waned in the UK, because we applied these policies very rigorously, then drug users started to look up. And we started to sit there as we dusted ourselves off and were looking at, mourning our peers who had died and looking with gratitude at those of our friends on ART who were now alive. We started to think, why did this happen? And of course, suddenly we started to be aware of the political context here. It wasn't just something that happened randomly. No, it was because we were marginalised people. It's because we were other. It's because we were outsider. And now we start to understand that Nixon and others were disgracefully, all the things we feared were happening and thought were paranoia, Nixon and his advisors have now told, or not Nixon's advisors have now told us, absolutely that was our motivation. We were trying to get the hippies, we were trying to get the blacks. And had we said that publicly in the past, people would have looked at us as conspiracy theorists. But in fact, now we know that to be the truth. So one thing that's really entered the drug user movement now is this huge championing of human rights, the demanding of saying we are citizens, and this is very much behind the shift in language to us now being called people who use drugs, not drug users. Then we move on to looking at drug law reform advocacy, and particularly I want to highlight, and then high-level advocacy, which is the advocacy that we're now seeing input doing at high-level meetings and drug users from regional networks working at high-level meetings. But one of the things, we first came up with this model in the 1990s, and we've revised it recently, and one of the things we've added is women's organising, because there is now a substantial growth in drug-using women around the world organising together to one, deal with the consequences that we all face as drug users, but the particular additional issues of gender-based violence, of particular violence from state actors, sexual violence from state actors who use prohibition as a reason to be able to break the law and attack a marginalised population. Okay, so one of the things we've been trying to do in COACT is trying to come up with a very systematic model of this work, because the Lancet, the Strategic Investment Framework, which was produced by the United Nations as a way of defining best practice, now states that community mobilisation is a core part of the response with people who are from key populations. Well, if it's a core part of the response, one, where is the investment? Two, where is the policy and theoretical analysis of this work? Why is it not being invested in the same way as other parts of the response? Because the reality is, I work in Afghanistan, in Myanmar, in Kenya, in various different places, and what I go around the world seeing is drug users fronting the harm reduction system, just like Nelson described, being the people who interface between all of you and the drug-using community. In fact, the drug treatment system, the rehabilitation system, most of the harm reduction system, the HIV treatment system, would not function if drug users were not brokering between the drug-using community and you. That's the reality. But drug users get paid a fifth to a tenth of what everybody else gets paid to take. I couldn't even quantify the scale of the risk that drug users are taking to play their role in the system. I met 2 drug users in Myanmar who had just done 2 years in prison for giving out needles and syringes. 2 years in jail. They gave up of their lives to give needles and syringes to their friends. Now, for me, I find that really hard to know that we are asking drug users to play such an incredibly powerful role within the system, and there is no way we can scale up needle and syringe programs unless we scale up secondary needle exchange, unless we allow drug users to give out needles and syringes to their peers. You're never going to get to be able to afford a system that could give out syringes at that scale without drug users doing it. And let me say the same. If you go for high-threshold opiate substitution therapy services that require people to come into clinics and spend hours queuing to get their medication, I met drug users in Myanmar who are farmers who were getting up at 5 o'clock in the morning and working till 11 o'clock in their first session of work each day was from 5 in the morning to 11, and we were asking them to dispense, we were dispensing methadone from 9 till 12. Now, these farmers were saying, you're stopping us from working, you're stopping us from giving an income to our family. So I think we really have to think about saying, if drug users are serious players in this work, then you've got to treat drug users and fund drug users as serious players. And that means a proper payment for the work that drug users are doing. Now, what we've come up here with COACT is a systematic model for trying to get people to work through a process of organising so that we initiate, we negotiate, we consult with people. And one of the things we're really encouraging people who use drugs to do is to go out and consult their peers. So we don't just have one or two tokenistic drug users who say, I'm the representative for all drug users, but you start off with a large-scale community engagement to talk to drug users about what they're doing. While you're doing that, you're recruiting those drug users to become members. So in Afghanistan, when we did a community consultation with over 400 people who inject drugs in one of the most high-risk environments I've ever worked in, 300 of those drug users became members of the drug user group. We then also picked out the leaders who were then brought into capacity building, who now form a team of drug users who are standing by for 2 years waiting for the Global Fund to give them resources. And what happens? Rather than using the team of 9 peer workers who've been trained, they go out and appoint a bunch of non-drug users to do the same job, and we will end up doing the work because those people don't do the job. And we've already exposed one harm reduction NGO in Afghanistan for selling 20,000 syringes to local pharmacies in a 2-month period rather than distributing them to drug users. And as Rahim, who's the head of the drug users in Afghanistan, said, he said, can you ever imagine a drug user doing that? Can you imagine a drug user being given syringes and not giving them to their peers? These people were systematically selling syringes that were meant to be going to one of the most marginalised populations. And one of the reasons we argue for drug user organising is because we would never do that, because these are our peers, these are our friends. We wouldn't take away life-saving equipment from them. So I just want to finally just touch on an experience with the UK. So this is looking at a period a bit earlier than David Nutt was talking about. This is when we formed a multi-drug user network in the UK. So we formed a network of 45 drug user groups. It came out of this period where 2 very formative things had happened. One, we'd responded to HIV. We'd been very successful. Drug users had played a pivotal role in mobilising to overcome HIV. And we'd also had the acid house generation, which created a huge sense of optimism among drug users, that we weren't apologetic about our drug use. We were all having a pretty good time. And these 2 things happened alongside each other. In fact, they were very much related because there was a sense of saving our communities and having a party being somewhat integrated. So we went out, we formed this network, we did a whole load of work. We managed to persuade Comet Relief, one of the UK's biggest charities, to donate money towards drug user groups. And they gave £250,000 to a programme of small grants to £5,000 to each drug user group. Now, compared with the usual programmes, this was the smallest programme they had ever run. This programme was independently evaluated, and the idea was that Comet Relief would then take us to all the other donors so that we could then show that this work worked. Comet Relief paid an independent company to evaluate the work. They said the work was the most exciting work they'd ever seen Comet Relief do. They said for the small amount of money they'd paid, they'd had fundamental systemic change of these drug user groups, making huge impact. Comet Relief couldn't even publish the report because they feared it would damage their overall fundraising to be publicly associated with drug users being successful. So then we didn't get to go to the rest of the donors, and the rest of our network collapsed as a result of it. And I have to say, the British government, when you see a government operating against you, is immensely powerful. And I look back on it and realise how heavily we were taken down, and it's destroyed drug user organising in the UK. It does not really exist it has never really recovered from this experience in the UK since. But the lessons I just want to draw out is that we can organise together, we can work together, we can make change, we can find international solidarity. We have faced setbacks, But we shouldn't be put off by those setbacks, and we should learn from them and come back out fighting. And for me, that's why I'm happy to go around the world working with drug users to help them be empowered to respond to drugs and prohibition and the human rights abuses against our community. Thank you.